Hey guys, so I am going to be going over the PowerPoint for Module 4. You still will need to go through this on the NHA website, but I've condensed a lot of it down into this PowerPoint. So hopefully this will just give you some explanations because I think it's kind of hard sometimes to go through just the module on your own. So I'm going to present now and show you my screen. Okay, let's see. Okay, so Chapter 4 overview is all about prescription filling. So we're going to start with receiving prescriptions. So when you receive a prescription, the pharmacy tech is usually the one who will receive it unless it's over the phone. Again, if you ever get a call in the pharmacy and it's for a over the phone, if it's an over the phone prescription, it's got to be taken by the pharmacist. But otherwise, usually the pharmacy tech will receive the prescription, and then it is the first opportunity for you to review the prescription for errors or missing information. So sometimes they'll ask the question, like, what's the first step when you are filling a prescription? And that is to review the information to make sure nothing is missing or that something that it's all legible, because sometimes if it's written out by a doctor, you can't like understand it or understand what it's saying. So you have to inspect all the necessary information and look for potential problems. Correct information is very important. If the pharmacist cannot read the information, then you will have you will have to contact the prescriber, which is the doctor who prescribed it, to verify what it says. So first, if you can't understand what it says, then you go to the pharmacist. If the pharmacist can't understand what it says, then you would go, the pharmacist would call the doctor who prescribed it. And here's just an example. I may come back to the screen when I talk about what needs to be on a prescription, but as you can see, up here is the healthcare provider's information. So this is the prescriber that prescribed the medication. It's got the prescriber's DEA number already on here, although for this specific medication, you don't need it because it's Lipitor, which is it's for high cholesterol. So it's an anti-hyperlipidemic, so just to lower cholesterol. So it's not a scheduled drug or scheduled controlled drug, but sometimes healthcare providers will put their DEA number on the top, like on every single prescription pad. So it's already on there if they need it. But for this one, you do not need a DEA number. Then this is the patient's name, the patient's date of birth, the patient's address, and the date that it was written. That's really important, like the date that the prescription was written, because they only last a certain amount of time after they're written. And then, as you can see, down here is the prescription of what the doctor wants for this patient. So Lipitor 20 milligrams. So you're gonna they're gonna be 20 milligram pills. You're gonna dispense 30 pills, and it's by mouth, which is PO, and then daily. So they didn't even take one by mouth daily, but you would infer that they would be taking one daily. Sometimes doctors aren't really explicit in their directions, so you would go with by mouth daily, one by mouth daily. Down here you would see refills. So this has 2 refills. If it doesn't say anything, like it doesn't have anything circled at all, not even no refill, you would just assume there are no refills. And if the patient calls and asks for a refill, you would have to say, well, we're going to have to contact your prescriber because it didn't say whether or not there were any refills. So that's really important to note, because sometimes the doctor will just not circle anything, and that means no refills. And then, so this is just saying the amount of medication to be dispensed, or that can be dispensed. And then this is the signature of the doctor and the date. And then brand exchange permissible means that a generic can be used. So, but if they put a dispense as written, that means it has to be Lipitor. It cannot be the generic. So most of the time, doctors won't give the brand name. They'll only give the generic unless it's really important and they like say that it has to be this brand, which most of the time they don't. Okay, so the next thing is prescription processing. So prescriptions are received in person, over the phone, fax, or electronic transmission, like an e-script. That's probably the most common now. It's kind of like an email. Pharmacies can also transfer prescriptions from one pharmacy to another via phone, fax, or electronically. Partial fills. This is one of those like key terms in this chapter is a partial fill. And they are when the pharmacy doesn't have enough medication, so they give part of the medication to the patient. And then if they order it and in a couple days it'll come in, then they can dispense the rest of the medication to the patient. They can also do a partial fill if the patient can't afford the full supply of medication. So I've heard, of situations where insurance will only pay like a certain amount per month, and you have to wait 30 days, but sometimes patients need it sooner. So they can get a partial fill of just a few until their insurance will cover it again, because it, only covers it every 30 days exactly or something like that. Or if they don't have insurance and it's just really expensive, they may say, well, I get paid on Friday, so can I just get 7 pills right now and then I'll pay the rest on Friday? And you could say, yes, we'll do a partial fill. So that's important to note, is partial fills and the reasons why you would have them. The pharmacy tech must also always verify if a prescription has refills, like I said in the last slide. And then remember that Schedule II controlled drugs cannot ever have a refill. They must have a brand new prescription each time. We hadn't talked about this, like the rules on scheduled drugs, but that's one of the rules with scheduled drugs is that, and remember, controlled drugs, scheduled drugs, that's a 1 through 5 stair-step category by the DEA. Remember, these are things like, hydrocodone, Xanax, anything like that where it has a potential for abuse. So those drugs, if it's a Schedule II, so that's the highest level of abuse, they cannot ever have a refill. They have to have a brand new prescription every time, okay? And there's rules around how, like most of the time for a Schedule II, you have to have a paper copy. It can't be over the phone, fax, electronic, that kind of thing. It has to be like an actual paper. So there's lots of rules, especially around Schedule II drugs. Okay, dispensing medication. Enter the information into the patient's profile. If it's a new patient, you're going to have to make a profile for them. And then you'll put the medication in there and print the label and make sure it's correct. So here's an example of a label. So this is what the patient would see, right? Electronic alerts show up when there's a possibility of an allergy, medication contraindication, etc. So remember in Module 3, we talked about allergies, medication contraindications, medication interactions. Any of those might, if the system sees that there's an issue with like another medication in the patient's profile, it might pop up. So like for this conflict, this says selection methoxazole. And the conflict is it's a sulfa drug, but the patient has a sulfa allergy, which is pretty common. So then you would be like, oh, we can't give this to that patient. We have to contact their prescriber. And at that point, you would probably contact the patient, but and ask like, hey, do you want us to call your prescriber and see if they, want to give you something else? Because clearly they didn't realize you were allergic to sulfa. And if the patient's like, oh yeah, great, thanks for not letting me die, from this allergy, then you would call the doctor's office and get another alternative. So that is what an electronic alert is. Elements of a prescription. So we went through this a little bit. I'll just list them out again. Patient's name and date of birth, patient's home address, the date that the prescription was written, prescribed medication name and dosage, information about dispensing alternative generics. They're called DAW codes. I talked a little bit about it before, but we'll talk about DAW codes here in a minute. SIG codes, which are abbreviations, so literally just like the abbreviations that you have learned, those are another word for those are SIG codes. Amount of medication to dispense, number of refills, and prescriber's number and information. Now, DEA number is only needed, a DEA number is only needed if it's a controlled or scheduled drug. Remember that, because there's always a question on there where it's like, what would hydrocodone need that is different than every other medication or something like that? Like, and the answer would be it would need, the prescription would need a DEA number that follows that prescriber. Yeah. Okay, patient profile. All pharmacies use computer systems for inputting, storing, and outputting information. Every patient should have a patient profile in the system. In the patient profile, you will find whatever background information you need to know, such as allergies, their medication history, third payer information, which is like insurance information, and their preferences. Do they want generics if possible? Do they want the brand name? Do they want to be text reminders, like texted reminders on their phone, that kind of thing. Prescription billing. Okay, so we're going to talk a little bit about what are third-party payers. So third-party payers are a kind of it could be insurance, it could be not, but someone else that's paying besides the pharmacy or the patient. It's someone else who is coming in and paying the bill, right? So when you have a third-party payer like insurance, government insurances, workers' comp, we'll go through the list of them here in a second, but you have information on their cards that you're going to have to get. So like a BIN number is a 6-digit number that is assigned to a third-party processor for electronic routing of transactions. This is basically how you get paid and how you go back and forth and how they pay you. So there's going to be a BIN number for that third-party payer. Member identification number is an ID number unique to the primary insurance holder on the plan, like the patient. You're going to have a person code, which is a code that identifies which household member under one plan is receiving services and prescriptions. So my students told me, because I had them look at their cards, they said they don't ever see, I had them look at their cards, but I also had them look at this in the pharmacy, like when they're filling, and they said that they don't even care about the person codes very much. You need to know what they are, but the main thing is you got to know what the member ID number is and the RX group number. The RX group number just identifies which plan that member has. So say the patient has Blue Cross Blue Shield. It's an insurance company. So they have like 80 different plans. You know what I mean? Like tons of different plans, different pricing, things like that. So under each of those plans is like differences in what they will pay for. So you have to have the RX group number to know which plan they're under. This is one of those things like I really want you to focus on and read through module 4 with the prescription stuff. Because one of the things that one of the things my students have said they've struggled with in the past on the certification exam is information about insurance. It was confusing for them. And it is kind of confusing, especially when you're not working in the pharmacy yet. So when you're in the pharmacy, you really need to ask those questions about prescription billing and information, because sometimes they won't teach you that stuff because it's a little more complicated and they'll just have you filling prescriptions. But it's good if you can get some information on how this actually plays out in the pharmacy. Insurance terms. So these are different kinds of insurances, different kinds of third-party payers. So you've got a PPO. They always ask this question on the certification test, and I don't even know why, because it doesn't really pertain to like pharmacy as a whole, but they ask about the difference between PPOs and HMOs. And the biggest difference is, and it's usually the answer is, that PPOs don't require pre-authorization or a referral to see a specialist. So if you break your leg and you have a PPO, you could just call up a specialist like a what's it called, like an orthopedic surgeon, and make an appointment for them, and they wouldn't require you to like go to your primary care doctor first. They would just say, okay, we can see you. But if you have an HMO, you would have to go see your primary doctor first and get a pre-authorization and a referral to see that surgeon, right? So the difference in price is that PPOs are usually more expensive, and they have higher deductibles, but you can go to whatever doctor you want to see. Like, there's some pros to it. HMOs are usually cheaper monthly, but they're more restrictive with who you can see. So I've been on both plans before. HMOs really suck because when I was on an HMO, I had to go to only like one hospital, one doctor. Like, it was really selective about where I could go. And then when I would get in, it would take like 6 months to get in to make an appointment. Like, it felt like that long. And then once you get in, you just feel like, I don't know, I was like in there and there's like 30 people in the waiting room. Like, it was a ton of people. And the thing is, HMOs just like, because there's not a ton of doctors that take them, it does make it like where it's harder to get into those doctors, or it can be depending on where you live, and they're busier, and so you might be waiting longer. Like, there's just some negatives to it. Whenever I've had a PPO, it's just always been better. Like, as far as the care I've gotten, like the doctor I went to just seemed like better doctors, but like, I don't know. It could just have been because the HMOs there just weren't very many in my area at the time, the doctors that would take the HMO. Workers' compensation is when you get, if you get hurt on the job, your work will pay for you to have workers' compensation, or they'll basically pay for your medical bills and stuff. Federal and state government insurance programs like Medicaid and Medicare. You've heard about that, obviously, before. In health science, we talk about that. Medicaid is for pregnant women and children under the age of 18. And Medicare is for the elderly or people who are disabled. Formularies are a list of drugs covered by insurance. So this could be anywhere. Like, hospitals have formularies, and it's basically this big list of medications that they will keep at the hospital. And if it's not on the formulary, then you can't get it in that hospital. And formularies in the insurance world are basically lists of what medications your insurance will cover. So every insurance will have their own formulary of like what they're going to cover. And some of them are like, they'll only cover generics, stuff like that. A claim is a request for reimbursement that the pharmacy sends to third-party payers. So once you come in, fill the prescription, you're going to send a claim in to that third-party payer saying, hey, we filled Mrs. Smith's prescription. We've already checked the insurance. It says that insurance pays 80% and Miss Smith pays 20%. So you guys owe us $100. And so they submit that claim to the insurance, and then hopefully the insurance accepts it and pays that $100 to the pharmacy. A copay or copayment is a portion of the cost of the service or product the patient pays out of pocket each time. Sorry, guys, I'm a little, I have like allergies today. So I feel like that's my life every day. Anyway, a copayment is basically what you're going to pay as the patient. And usually you've either got a copayment, like a amount you pay every single time for this medication, or it's a percentage. And then adjudication is the process of submitting a prescription electronically to the proper insurance company for approval and then billing. So it's basically this whole process of like sending in the claim, getting the money back, all of that they have a name for it. It's called adjudication. It's just the process of all of that, of the pharmacy getting paid. Okay, so Medicare, know the differences between Part B and D. These are questions on the certification test. That's why I put it in here. They really want you to kind of know the differences between Medicare B and D. So Medicare, like I said, is a type of insurance program for the elderly or people who are disabled. One major difference between Medicare Part B, as in boy, and D, as in dog, is that Part B, as in boy, requires paper claims only. It's just a random thing that they require. Medicare Part B covers diabetes supplies and durable medical equipment. Part D covers prescription medications. So this is the main thing you need to remember about B and D, okay? Part B, they just make a just this like provision that just diabetes supplies and durable medical equipment like things like diabetes testing kits, diabetes like any kind of like devices, diabetes devices. It may not just be diabetes devices. They say they're gonna pay for a walker or a cane or something like that for a patient, and you guys have those equipment in your pharmacy, because some of them do. Medicare Part B will cover it, and you would have to send the paper claim in for that. If it's medications, just medications, prescription medications, Medicare Part D, as in dog, covers it. And it doesn't have to be paper claims. So those are the two differences. Just remember Part D covers medications. Like, I don't know how you can remember that, but you just got to remember that. And then basically there are strict document requirements for Medicare. And so this is important because the pharmacy, if they don't send in the correct way or the correct documents, they won't get paid by the government because Medicare's in the government, and government stuff just seems to always be crazy and not work well. So you have to do everything right to get it paid for. Okay, so DAW codes. This is we're almost done. DAW codes have to do with brands versus generics. So, like in that first slide I showed you, it said, let me go way back real quick, you guys. Remember when I said down here, prescriber signature, and then at the bottom it says dispense as written or brand exchange permissible. This is basically telling you what the DAW code situation is. It's just not giving you the specific DAW code, but it's saying you can have a generic if the patient wants it. Okay, so let's go back this way. Sorry, guys. I just had to show you that. So whatever code applies must be sent in with the claim for insurance. So the doctor may not put DAW code 2, but they may put generic is fine or something, and you have to know which is the right one, okay? For example, if a patient's doctor authorized a generic substitute and the patient accepts that generic, a code 0 would be added to the claim. So in this little thing here, it says DAW 0, generic is being dispensed. Another example, if a doctor authorized a generic, but the patient refused it, like the patient said, no, I want the brand name, code 2 would be added to the claim. Patient requested brand. Now, here's why this is important. Because insurance sometimes will only pay if the physician requested the brand. But if the patient requested the brand name, they may not pay. So they want to know exactly why the patient's getting what they're getting. If the generic is being dispensed, that means the patient accepted it, the prescriber or the doctor said yes to it, and most likely that is going to get paid for by the insurance. But if, one of these scenarios happens, say the patient didn't want the brand, but the doctor said that, or the patient didn't want the generic, but the doctor said the generic was fine. You put that in here, patient requested brand, and you could tell the patient, like, hey, we're going to send this into your insurance, but the insurance might not cover it because it says they only want to cover generics. So this is why this is important. They do have you memorize this. So this is just a shortened version. You'll see, I think the next page, I have longer ones. It's just like, this is just a little bit more shortened. I thought this is easier to understand than this one. And the one in online and in the book is a little bit more harder to understand, but you need to memorize these and know what these are. Okay, they do ask you this in the certification exam. They want you to know all of these. So this is something you're going to have to memorize. Sorry, guys. There's a lot of memorization in this class. All right, so that is it on Module 4. I want you guys, let me stop this real quick. I want you guys to make sure that you that you have gone through this module on your own on NHA. For some reason, y'all are not getting the modules done very well, but they are really important. So make sure to go through them and then take the quiz. That's going to be due. So I'm going to put that in as what you have to do for this module. So that is it for module 4. I'm going to stop now talking so I don't make this super long. I hope you guys have a great day, and I hope this was informative. All right, bye.